Hi everyone, and welcome to today's episode of Epworth Live. We're here as part of Endometriosis Awareness Month at the Epworth Freemasons Endometriosis Support Group, and we've got an amazing panel here that we're going to hear from today. If you have any questions, comments, or stories you'd like to share, feel free to post them in a comment or send us a direct message. All questions will be read out anonymously. Without further ado, I'll hand over to Wendy, who's going to introduce our panel.
Thanks, Louisa. And just a thank you to Epworth for allowing us to pop this on. I'm Wendy, the gynae nurse at Epworth Freemasons. And I'll just introduce the panel. We've got two people missing at the moment. Melissa Cameron's on her way from theatre, and our pelvic physio Kiera is on the way as well. So we've got Liz over here, Liz Crocker from Living Well Services, and she's a health psychologist. We have, you get these all right. We've got Shirley Weber, who's from Monash, and she's a specialist dietitian. Chantelle Otten, who's a specialist sexologist, and very famous because I've seen you in lots of other things. And we've got Beck O'Hara, who's a researcher at Monash and is researching for your PhD, is that right, about endometriosis. We've also got another researcher here, Nicole, tonight, who's doing her master's, and she just wants to have a little quick word about her study. So we'll just move over.
And I'll just squeeze in. Hello everyone, my name's Nicole Fernley and I'm currently studying a Master's of Health Science at La Trobe University. I'm doing a little research project on endometriosis and specifically on women's blogs. Now I'm asking for some help. Can you please send me blogs you read or things so that I can start collating them? My email is 19282567 at students.ltu.edu.au. I think I got that right. Anyway, I look forward to hearing from you. Just send them my way. Thank you.
And now we're just going to hear from each of the panel members here, the experts, about what kind of things they do to help with endometriosis management. So Liz Crocker is going to start us off, and here's her brand new webpage. So what do you do for girls with endo, Liz?
Okay, so I'm a health psychologist, and what I do is I really support women to cope with the emotional and mental and energetic drains of endo. One of the big issues that women have trouble with is coming to terms with their expectations of what they like to be doing, what they feel they should be doing, and what they actually can do. And so that often creates a lot of feelings of failure or disappointment in themselves and a lot of self-judgment. And so what I do is I give them tools and I help them learn about their energy and how, as an energy system, we only have 100 units of energy at any given time. Now, we as women really never really believe that because we always think, oh, I know I can push the envelope to 110, 120, and I know I've done that. But when we do that, we always suffer in some way, either in our health or our relationships. We get narky, or no, there is some cost. And so one of the big things in learning to deal with endometriosis is the fact that having a chronic disease like endo actually takes a fair amount of your energy. So that doesn't mean that you can't have a life, but what it means is that you need to learn how to pace yourself, how to balance things, to take your endo into account. And so that you actually start to feel that you're empowered with your endo, not that your endo is running you. And so if you visualize yourself as an energy system, like a little round ecosystem, then we always have good energy coming in to support us to do what we want. However, if we have a lot of draining our energy, it could be, family relationships, people who, you can have friends who are on the phone for an hour, that type of thing, and really drain your energy. Or your expectations or the things in your head. Well, then what I do is I give you strategies to learn how to plug those leaks so that when good energy is coming into your system, you have an opportunity to use it productively and in a way that makes you feel you have some control and some power over your life. Because one of the awful things with endo is that feeling of being disempowered and that your body is letting you down. And so that's kind of basically what I do. I'm just excited today. I've launched my new website. And I'm moving more to online and phone Skype sessions, because I find a lot of my women really don't want to go out. If you're having a bad day, you just want to sit with the heat pack, warm in your bed and your phone, and have a session in that way. And so I find that really is much more helpful than having to get in the car and come and see me. So that's kind of what I do. Thank you.
Thank you, Liz. Now we'll just move on to Shirley, and we'll just grab Shirley.
Yeah.
Is that the right one?
Hi everyone, I'm Shirley. I'm a dietitian. I work in private practice, but also work for Monash University and the Alfred Department of Gastroenterology. So with nutrition, I really help patients to find what works for them, and I'll go into a little bit about what we know about endometriosis and nutrition. So as you all know, endometriosis is a chronic condition that affects 10% of women of reproductive age, and it can take from 7 to 10 years for women to get an actual diagnosis from their first point of seeing a GP to then getting that final diagnosis. And a lot of that is because we see such an overlap of endometriosis symptoms with other health conditions. So an area that I very much work in is IBS, and the symptoms that are highlighted in red are the ones where endometriosis and IBS overlaps, and so it's no surprise that we do see that misdiagnosis of endometriosis as being IBS. So it is important, if you have had that IBS diagnosis, to know about some of the red flag symptoms, and those are pain with intercourse, heavy periods, pain in back pain and pelvis, exacerbation of bowel symptoms with menstruation, a family member having endo, and also difficulty conceiving. So if you do have any of those symptoms, then it's important to go and see your GP. Now, some of the recommendations that we can make nutritionally for women with endo is that because of this overlap between endo and IBS, one of our researchers at Monash University, Judy Moore, did her PhD investigating if a low FODMAP diet can help women with endometriosis and managing those bowel symptoms. And she found that, yes, actually a low FODMAP diet can help with reducing those symptoms for women with endo. Now, for those who are not familiar with FODMAPs, FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. It's a mouthful. And those are fermentable short-chain carbohydrates. They rapidly ferment in the gut, and that contributes to gastrointestinal symptoms. And so reducing those carbohydrates down means that many people are able to reduce their gastrointestinal symptoms, and many women with endo can reduce their symptoms down that way. So if anyone is considering doing a low FODMAP diet and trialing that for symptoms, it's important to see a dietitian, because there are 3 phases to the diet, and a dietitian can help you tailor those 3 phases to you, so making sure that you're going through a strict low FODMAP phase, and then reintroducing FODMAPs that you tolerate, and re-challenging FODMAPs, and then working with you to maintain symptoms by just following a diet that's excluding the FODMAPs that you have shown to be triggering too. So the low FODMAP diet has been quite beneficial. Another thing to consider is looking at the fats that you are having. So choosing some of the good fats rather than bad fats. So the good fats being the monounsaturated and polyunsaturated fats, fats that you find in sort of fish sources, salmon, tuna, and anchovies, and omega-3 fatty acids are really the ones that have been shown to reduce inflammation in women with endo. Oh, oops, sorry, I skipped one. So the other thing that we look at is that women with endo have an increase in free radicals in their bodies, and this can contribute to oxidative stress and further contribute to inflammation. So by consuming a diet that includes antioxidants, these foods work to bind free radicals and reduce the inflammation in our body. So we're looking at good sources of antioxidants, so from foods that contain vitamin C and vitamin E. And we also want to look at fibre, and fibre can assist in reducing excess estrogen in the body, and it does that by binding to the estrogen and excreting it. And estrogen, if it's not excreted, can contribute to that increase in inflammation that we see in the body, and that heightens pain. So it's really good to aim for 25 to 30 grams of fibre per day. Consuming foods such as vegetables, legumes, nuts, seeds, fresh fruits. So really, the best diet is a varied diet, and we're looking at sort of more following a Mediterranean style diet, where you're choosing those healthy fats rather than choosing saturated fats, also eating more plant-based foods, and choosing poultry or fish rather than going for red meats, and just being very active. So as a dietitian, just making some of those lifestyle, giving lifestyle advice is how I work with women with endo.
Thanks very much. Fantastic. All right, lots of things to think about there. Yeah. We're going to move on to Chantelle. I'll just bring it. Yes. Okay, right. So what can you do to help women with endo?
Yeah, good question. Well, endo, you have chronic pain, and chronic pain may lead to anxiety, may lead to self-esteem issues, mobility issues, but also sexual pain. 80% of chronic pain patients do tend to have symptoms of sexual pain, which is neglected in the treatment process, and of course not well known how to treat by medical professionals, gynecologists, physios, etc. So physios play a really important role, and I'm looking forward to the physio getting here because we work as a team. In fact, I work with everyone who is on this panel as a team. My job is as a case manager. Sex is a symptom for many other conditions that are going on. And I put on my detective hat and I listen to your individual questions and plan out how we can get you, we meaning myself, and I have a team of 6 other sexologists who work for me in private practice, how we can get you to a place where you're having a very satisfactory sex life. And that doesn't necessarily mean that you're going to have a penetrative sex life. It may mean that you'll have more of an erotic, experimental sex life, looking a lot more at outer course, looking at intimacy, looking at working with your energy levels, and getting really close to your sexual partners, essentially, in a way that's non-threatening. When you have a condition like endometriosis, your body starts to tense up a lot because of the pain, but also because you just don't feel very good. This can lead to an aversion of intimacy. So your partner may touch you and you go, oh no, it's just not tonight, I'm not in the mood, it's just not the time. And that might not actually be because you don't want your partner to get close to you, but you start thinking, well, it's going to be painful when I have sex. or I'm going to have painful symptoms after sexuality, or there is problems with bladder functioning, or maybe defecation pain, for example, and this all leads to you going, you know what, I'm just going to toss it out, and it's just not worth me getting that close. A lot of people with endometriosis tend to avoid relationships as well for a long time, especially if they don't have a diagnosis. If it's in that 10 years before diagnosis, they start to feel pathologized. There's something really wrong with me. I don't know what's going on. I really don't know how I'm going to be able to date someone in this state that I'm at. I can't even go on a date, for example, because I just am stuck to the couch or stuck to bed. And for me, it's about working with a psychologist or with a dietitian to get you feeling really good, but also saying, you know what, we can compromise and we can come up with boundaries, and we can also just educate your sexual partner and work with you as a team against the problem, rather than you against your partner or you against endometriosis. So that is my role. Any sexual questions that you have, please throw them on the thread so I can answer them for you. I don't have a general list because it's so individualized. Everyone has their own concerns when it comes to sexuality. So thank you.
Thanks very much, Chantelle.
Pleasure.
Moving on to Beck about research, and just also to introduce Kiera, who's just coming in house. Do you want to pop on in?
Should I go over that way?
Yeah, go around that way. So Kiera's a pelvic physio. So we'll hear from Beck first, and then I'll get you up to him.
So I'm wearing two hats today. One is an endo researcher and the other is a volunteer with Endo Help. So I'll just give you a bit of an overview of both of those. So my study investigated how women manage endometriosis in Australia. So 620 women completed my survey, and then I did follow-up interviews with 15 women. And I just thought I'd share some key findings from the study. So my study showed that on average, women experienced a 6.4-year delay in diagnosis, and that's consistent with international studies that we've seen published. Many experienced ongoing symptoms, so over 60% still experienced period pain, pain with sex, 82% experienced pain outside of these times, so something that we would consider sort of ongoing chronic pelvic pain. Both physical and mental quality of life were impacted among women with endometriosis, and when we compared that to the Australian general female population, physical and mental quality of life was a lot lower among women with endometriosis. And I'm interested in the role that women themselves play in managing the disease, so something we call self-management. So self-management is the active participation of the person with the disease in their care. And we do that through informed decision-making, working with your health team, and feeling confident in your ability to manage the disease. And what I found that is higher confidence was associated with like a lower likelihood of using prescription pain medications. It was also associated with greater quality of life. Now, this has important implications for practice in that if we can support someone to feel confident in their ability to manage the disease, then they may be able to better cope with that disease. So this means we need to provide accurate information at diagnosis. We need to present the different treatment options available, but also the risks and side effects of those treatment options so someone can make an informed decision. We need to involve the person in working out a plan that's right for them. And we need to highlight the steps that they can take themselves in order to better manage the disease. So I'll just give you a bit of an overview of Endo Help as well. So Endo Help is a Victorian charity, and the main focus is on upskilling nurses to support people with endometriosis. And we're doing this in a number of ways. So we've got a proposal that's with the government at the moment to run a pilot nursing program in Warrnambool. So the idea with this program would be to work with nurse practitioners in a community health setting to be able to provide support services for people with endometriosis. And we're hoping that this helps reduce some of that waiting time while people are waiting to go see their specialist so that they can get a plan of action. So essentially the aim would be to replicate the Canberra Endometriosis Centre model in a community setting. So this is where someone can come in, meet with an endometriosis nurse, talk about their symptoms, their history, any concerns they're having. That nurse can then help them develop a plan of action, and then the nurse can also refer them to allied health staff and specialists as necessary. We're also involved in working with the Australian College of Nursing to develop a unit of education about endometriosis that nurses can undertake. And our fundraising efforts are really going towards generating some money for some scholarships so that we can support nurses to go through that program and provide practical endometriosis training to those nurses so that they feel confident in their ability to sort of manage in the community setting. So if you're interested in supporting our efforts, you can volunteer through our website, endohelp.com.au. We're also developing a knowledge database on the website, so if you'd like to contribute articles or tips and tricks for managing endometriosis to help support others, then you can also do that through the website as well. Thanks.
Thanks very much. Welcome to Melissa Cameron, who's just running from theatre, and also to Kiera Hannigan, who's a pelvic physio. So we might flick up to you, Kiera, and see how you can help when we can do off.
Absolutely. So in terms of physiotherapy, I have done pelvic floor physiotherapy, a certificate in that, which then brings you to a space where you start to get referred, women with endometriosis, because there is a tendency to experience some degree of pelvic pain, and that's usually a chronic or persistent state. And so pelvic floor physio looks at identifying what pain the woman's experiencing, so whether that's issues with bladder, that can be a variety of symptoms, and it can also be pain associated with using the loo to do a wee. It can also be issues with bowels, and the other one that often comes up, as you've mentioned, is painful sex. So we work a lot in that space as well and help women with those issues. And more broadly, looking at how women might want to actually engage in exercise or their daily activities that they're finding their pain is limiting them to be able to do. So when you come to see someone like myself, we take a nice long history and get a really good picture about what your symptoms are and what your issues specifically are, because they are often quite different from woman to woman, what you want to be able to achieve going forward, what your previous management has been, what your current management and professionals that are involved in that management are doing, and what's helping and what's not helping. And essentially we work to, I often feel like we're unpacking quite a layered situation for women. There's a lot going on, and there's lots of disciplines involved and lots of different areas of pain, and it can get quite confusing as to what's causing what and why. So we really work through that in a methodical process to help understand what is actually causing what, and then what are the contributing factors and what we can do about those contributing factors. And we can't always completely get rid of pain, but we can often make quite a big difference in the hands-on treatment we do, lots and lots of education, which you mentioned. That's a really important thing, to be educating women about endo, but also about what pain is and what it does to your body, and just giving that person a sense of control and understanding often then reduces the pain experience in itself. So we look at lots of different aspects of your life, of your posture, of your mechanics, of your pelvic floor, and we sort of, as I said, unpack that, put it back together, and slowly work towards achieving your goals.
Excellent. And I've just introduced Melissa Cameron again. So you're a specialist endosurgeon and IVF as well. Okay, all right. So what can you offer women?
So
with endo?
I guess a bit of my background is I did most of my training always with an interest more in gynecology than obstetrics, and I always had an interest in surgery as well. And so in the later years of my training, I actively sought out experiences and sought out working with people who had a big interest in endometriosis, which I think is, I mean the training in obstetrics and gynecology is 6 years and it's quite vast. The people that do a lot of endometriosis work, surgery and other work, it's usually another 2 years on top of that, and it really depends what you get exposed to over your 6 years as to what skills you gain. And all of us are good at something. That's what I tell people. We're all good at something. Some people are good at doing endometriosis stuff. Some people are really good at looking after pregnant people and delivering babies. Now my work is, I work privately but also publicly, and in the public system I'm at the Women's Hospital and I run the Young Women's Gynae Clinic there. So I'm seeing teenagers from about the age of 13, 14 up to around about 19. Sometimes I hang on to them for a bit too long because I like seeing them. But it's a great little clinic. And I'm looking at a range of things, but I'm seeing women at a young age coming to see health professionals for the first time about pain and so on. My approach has really changed over the years. I think it's really quite an exciting area, being involved in pelvic pain and endometriosis. And I mean, I've really changed. I hardly ever do things myself. Like I can operate, I can use hormones, but it kind of, most of the tools that I'm really good and experienced at using, I hardly ever have anyone where I don't also refer to physio, and I'm also talking to people from a diet perspective, because it's just, as you mentioned before, it's layers and layers, and it's bigger than what I can deal with. And I mean, I still see people who have been through years of endometriosis treatment or years of pain where they haven't had the opportunity to see other people. And just some doctors don't know about what physios can offer and dietitians can offer and so on. Or especially if you're rural, there's not as many options for anything. I mean, I'm from Adelaide. There's no Adelaideans, which I love Adelaide. But from a professional point of view, I have found that moving to Melbourne, there's more people, there's more exposure to different things. So if you think also, I can be just a gynecologist, just doing sort of fertility stuff and endometriosis, rather than having to do other things to kind of keep myself busy. Whereas if you're in the country, often you have to be a bit more general because there's not that many women, who will present with one particular problem. So that's one I think is one of the big issues with being, say, from the country. But from my point of view as to what I can do to help, I sort of feel like sometimes I'm a bit of a linchpin. But everyone probably feels like they're a bit of a linchpin because we really should all work together to try and address all these different areas. Because as an individual, I've only got limited skills in fairly small area, but I can still ask questions about it and still identify areas and work out who else the best people are to be working with as well.
Excellent, thank you. So we might move on to some questions that have been sent in, and we've also got an audience here. Welcome everybody who can call out questions as well. But given that you've just been speaking, Melissa, we might just have one about surgery. Is there a way to prevent adhesions after surgery, or anything that can be done besides further surgery to keep the organs separate or adhesions mobile so they don't hurt? I've had 3 lots of surgeries, ablation, 2 of excision, and constant pain.
Yeah, I think adhesions, as a surgeon, adhesions are one of the most difficult and problematic things we have to deal with. There are various surgical techniques that can be employed to try and reduce the risk of adhesions, such as having laparoscopic surgery done. Over the years, there's been hundreds of different lotions and adhesion barriers and fluids that can be put into tummies to try and stop organs coming back. One of the big issues, I think, with endometriosis is we can treat what we can see, we can separate organs, we can try and stop them sticking back. But endometriosis can come back, particularly if we're on a sort of cousin of endometriosis, adenomyosis, and if you've got the disease of the cervix, then that in itself is going to cause adhesions and recurrence of adhesions. So I think that is a very difficult problem most of the, I guess, preventative side of things is from a surgical approach. So as a surgeon, we're taught to, prefer laparoscopic over open surgery. You certainly get less adhesions in that scenario. Being very careful with bleeding during surgery. Endometriosis is, I don't know whether anyone's seen photos of pelvises after they've been operated on for endometriosis. They often look worse than what they did at the start. And they often ooze a lot. It's a bit like when you fall over on the asphalt and you get a graze and you just get that little bit of oozing. It's like that. And it's trying to really pay a lot of attention to detail to minimise that much bleeding, because in that setting of bleeding, that's where adhesions are more common and more likely to occur. But yes, look, it is a really difficult problem. It's, every couple of years a new something will come out, whether it's a physical barrier or a fluid. That it's an area of research that people are continually trying to improve things from an adhesion point of view.
Any comments from you, Kiera? Any physio that can help with that?
Gee, not that I specifically know. The only thing that comes to mind is a technique called visceral mobilisations, which isn't something that happens a lot here in Australia. It's more of a European technique, so you can be trained in visceral mobilisation, which is supposed to help, as it says, make the organs more mobile in the abdomen, but I personally don't do it, and I don't know anyone in Australia that does, so we need to...
Can you explain it a little?
It's a really gentle technique, from what I understand, that apparently works at keeping the fascia that surrounds all the organs mobile. It's probably as best that I can
Google it. I better Google it.
Yeah, I think it is difficult. The organs I think are most difficult are ovaries, because sometimes they'll stick down like a pancake covered in melted cheese. We always use food analogies in that sense, but they do stick down to the point of they're really difficult. And the problem when you separate organs is often you end up with two raw surfaces. And then it's those raw surfaces that stick back down again. Yeah. So I think for some adhesions, like if you had adhesions between lips or bowel, which doesn't often happen with endo, I can imagine something like that could help, perhaps.
It's certainly not well studied to suggest that it actually does a whole lot, but when you talk about adhesions, that's what springs to mind, that people in the physio world or the osteo world would attempt to try to help manage that scenario, but I absolutely can't say that I've had experience that it's been really successful.
From an ovary point of view, I imagine the ovaries are they're quite deep. I don't know how you get
in there.
Physio.
Yeah.
So why do the ovaries hurt so much with ovulation in some patients?
Well, I think it's because if you've got the sidewall here and the ovaries here and stuck, is when you ovulate, in the lead up to ovulation, you'll form a cyst, so that's the sort of sac of fluid that the egg's in, which will be a couple of centimetres big. And if it's the ovary just normally hanging a bit like from a stalk, so a bit like a cherry, so if it's getting bigger, if it's growing, and ovaries are very active, they're really remarkable organs. They do a lot of changing in a short period of time. But if they're getting bigger, then if it's not stuck, it can just move out of the way. But if it's stuck and it's trying to expand, it's a bit like having a pimple. You can't get bigger, and so it starts pulling all the tissues that it's stuck to. So I think that's why you get so much discomfort with ovaries around ovulation as well.
And we've just got speaking of food, this is one for you, Shirley, about could you comment on the role of cow's milk, specifically A1?
So beta-casein. Unfortunately, there's not a lot of research. I think I'm going to sound like a broken record saying that. Beta-casein and endometriosis, there's actually no research. But we do know from the research that's out there about comparing A1 and A2 beta-casein that the A1 beta-casein amino acid chain, when it breaks down in the small intestine, it actually releases a peptide called BCM7, beta-casomorphin 7, and that binds to the opioid receptors and can cause inflammation and actually contribute to gastrointestinal symptoms. So yes, there is a bit of theory around it that it can contribute to inflammation, but as for specific evidence yet. There's nothing there.
But it kind of makes sense if your gut's misbehaving. We've got everything in the same basket, and it's a small basket with lots of stuff in it. So if your bowels are a bit irritated, everything else is right next door. They're all neighbours.
And just one about having sex. This lady says she's got a very high pain threshold. So if she is active sexually, is she going to damage herself if she just ignores pain? It's a bit tricky one, isn't it?
I think that's an interesting question though, because if you look at the pelvic floor physio side of it, if she's got a high pain threshold, what positions is she using? Is she really going up deep into the pelvis? Is the pain on penetration, or is it a lot deeper? I don't know if she can necessarily damage anything through the sexual intercourse, but she might have a little bit of trouble the next few days after sexual intercourse in terms of mobility and feeling good down there.
Do you find, like, on the whole, patients who've had endo in the pouch of Douglas, which Melissa might explain, are they the ones who have the most problems, do you think? In that's where the endo is with
sex, and the uterosacral ligaments, which are the little ligaments that sit. The pouch of Douglas is the little pouch behind the uterus and the bowel, named after a male Scottish anatomist. A lot of bits of our body and named after men. And so it's essentially right at the top part of the vagina, just behind the cervix if you're looking into the vagina. So often with deep penetration, that's where you'll get pain. But I often find there's also a muscular component to the pain as well.
So my comment would certainly be that sex is supposed to, we would hope, that it's an enjoyable experience, that it's pleasurable to some extent, and if there is pain associated with it, that can complicate the situation, and it can lead to your pelvic floor muscles becoming overactive and sore and tight, which can lead to more pain with intercourse as time goes on, as opposed to, I'll just grit my teeth and bear it and hopefully next time it'll go away. We don't seem to see that pattern. It tends to become worse and worse and worse. So I would absolutely encourage anyone that is having pain with sex to get some women's health pelvic floor physio input, because there can be a musculoskeletal component to it where your pelvic floor is overactive and quite tight, and we can work at that, and it's really quite successful. The other thing is, you've sort of alluded to, is positionally you can change positions and investigate what positions, experiment with what things feel better, and certainly use the positions that don't cause pain.
Or, there is the option of out of course, so not having penetrative sex. And what you were describing is a condition called vaginismus. It would be if I grabbed a pen and, threw it at your eye would start blinking automatically because you don't want the pain to go in there, and then at some stage...
It's a protective mechanism.
Yeah. So, which then, would lead to a lack of desire. If you're constantly having painful sex, you're not really going to desire sex, so then you start having an aversion to sex, which can then cause relationship issues. But we don't often hear people saying, I just grin and bear it and it's fun. We often hear people saying, I really don't want to do it. How am I going to get to a stage where I can have intimacy? And my job is to work with the physio to look at
people can grin and bear it for a long time, but it doesn't seem to actually help in the long run. It tends to make things more complicated. Makes it harder in the long run. So I very much encourage, if that's a problem, then talk to some health professionals that can help you.
So, Wendy, can I just interrupt? Someone from the Facebook page has asked a question about alleviating the guilt associated with painful sex. So, especially for after they've had intercourse and then the partner has felt extreme guilt about the pain that's been caused to the woman. So, do you have any comments on alleviating the guilt or the
I would just say it's a good time to maybe talk to a sexologist about how to be experimental in the bedroom without having to do sexual acts that are going to induce pain, for example. And we don't have a great sex education in Australia, and you know, how are you meant to know these kind of things? How are you meant to know how to be erotic with your partner if you're not very comfortable with communicating about sexuality, but B, if you're just not quite sure what to do, essentially. And there are so many ways that you can have a very satisfactory sex life without having any type of penetration. Obviously, if you're trying for a baby, there are different ways of going about that. But if you're just doing it for fun or to be close to your partner, come talk to me about it. Come talk to one of my staff about it, because you can be very satisfying.
And adding to that, as you start to then have a relationship that's not based on the sexual interaction has to be about penetrative sex, the intimate interactions become a lot more positive, which helps both partners psychologically, which then actually has a positive impact on pelvic floor, and if it's overactive, and you can actually get to a point where penetrative sex is 100% an option, but you often need a little bit of therapy and intervention from someone like myself to guide you in that space just a little bit.
Liz, do people come to you when their relationships actually break down because of endo?
I actually haven't had many of those clients at all. I've actually been surprised at the amount of support that women get from their partners, and the nurturing and actually what they put up with. Like that, you know, they're very supportive and nurturing and understanding, and get the heat packs and are there. I haven't had an experience. Perhaps I'm just thinking now. Years and years ago, I did have one relationship that broke up, and it was a reasonably new one, and he just said, I'm not up for it, type of thing. But when I've had established relationships, I haven't had that experience. Have you, Chantelle?
Yeah, no, I definitely have, but they are repairable. You know, you can build back up, especially if you have a good foundation. We don't often get into a relationship that's just based on sex, and we don't build a relationship to break it down. People really want to look at options to make sure that they can stay together. So definitely you can rebuild from that place most of the time.
And Melissa, if a patient comes to you because they're not getting pregnant and they come to you for IVF, they've already got the stress level of endo. How do they then cope with that whole IVF roller coaster?
Trying to get pregnant, whether you're using IVF or not, for a lot of people is really, really hard. It's not for birds and bees and butterflies and easy. It's often very difficult. The one thing I'd say is it doesn't always mean IVF. And it's not always because of endometriosis that you're not getting pregnant. Sometimes, most of my couples that I see, it's multifactorial. So we have to remember, to get pregnant you need eggs, you need sperm, and you need a uterus. So any of those three things can have issues when it comes to trying to get pregnant. So it doesn't always mean IVF. And I think as women we take a lot of responsibility for for getting pregnant and for not getting pregnant. And sometimes we need to share that responsibility a bit as well. So I think from a stress point of view, it's very, very difficult. But we try and support you as much as possible, and that's where I think it's really important you have a team that you're seeing who is someone you feel like you can talk to, and you're getting out of them what's important for you as well.
Any other questions from the audience at the moment?
I've got a direct question. There's a lot of talk about the benefits of probiotics. Can you talk, is there anything to that? Is there anything that you recommend in terms of those sorts of supplements or additions to the diet?
Yes. So with probiotics, it really depends on the strain of probiotics that people are taking. Unfortunately, we still don't know enough about probiotics and which ones are the beneficial and which ones are not. So sort of still in that grey area. And just making sure that you're having a balanced diet is sort of where we're going, just because it is such an unknown area still. But some people have found benefit from taking probiotics for gut issues, and so there's no harm in trying it. So yeah, definitely worth a try. And also important to know that if you're trying one type of probiotic and not seeing any change, try a different strain and seeing what works for you, because what might work for my gut bacteria won't work for another person's gut bacteria, because we all have such diverse gut bacteria. So it's a bit of a grey area.
Thank you.
Do you know much about green tea as well in terms of endometriosis? I've seen some research around that.
I've seen a little bit in terms of it being antioxidative and helping with inflammation. But yeah, just that is what I've seen, but I haven't really seen any hard evidence.
Now I've got another question here from the net. I know hysterectomy isn't a cure, but I have endo, PCOS and adenomyosis. What are the pros and cons of a hysterectomy, and what if I still have pain after I have one?
I mean, each situation is so individual. Generally, I mean, the advantage with hysterectomy would mostly be in treating adenomyosis, which can present with pain similar to endometriosis and often heavy bleeding as well. So the disadvantage is if there's other things going on, such as muscular component to pain, nerve component to pain, then you're only going to get limited benefit. And if you're only having hysterectomy without also treating endometriosis, then the endometriosis will still be there. Generally, when gynecologists use the word hysterectomy, we're talking about just removing the uterus. If we use the word oophorectomy, we're taking out the ovaries as well. And the ovaries make estrogen, which is like fertilizer to endometriosis. So if you leave ovaries in place and just take out the uterus and don't treat any other endometriosis that might be there, then potentially you're not actually helping most of the problem. But also addressing the other areas as well, not just sort of going, I'm a surgeon, that's what I'm going to do, without also addressing other areas. From a PCO point of view, hysterectomy it will not do anything to make that better or worse. That's happening from a different mechanism altogether. Obviously, having a hysterectomy means that if you haven't had children, then you're not going to be able to carry a child yourself. And taking out ovaries, we would generally not take out ovaries in someone who is younger than the menopause age of around 50. I mean, there's always exceptions to that rule, but that is generally from a overall health perspective, you're better off with your ovaries rather than having your ovaries taken out. Without your ovaries, you're at a higher risk of osteoporosis and fractures from that, and from cardiovascular disease as well. So I think it's something, if you're thinking about hysterectomy, unfortunately a lot of people get told at very young ages, oh, you're going to need a hysterectomy. Medicine's always advancing, gynecology is always advancing, there's becoming more and more less invasive methods to treat people, but if it's something you're thinking about, then you really need to discuss the pros and cons. And I mean, to be honest, with my group of patients, by the time we get to hysterectomy, we've usually tried many, many other things. It's rarely the first thing on the list of things to do. And to be honest, most of my patients, the most common feedback I get about from women who have had hysterectomy is they should have done it years ago. Now, obviously, that's in the context of people where we've been working maybe for years towards this, and it's something that we've all come to agreement that this is the thing that we need to do and this is the time to do it, rather than feeling it's enforced upon you or a choice that you don't really want to have to make, particularly in the context of having a pregnancy. If you haven't had the opportunity or you've been trying to get pregnant and haven't been successful, then having a hysterectomy can be quite devastating as well.
And then we've got a woman who's had 12 operations, another who's had 9, wondering how they can best prevent recurrence post-op.
Yeah, look, I think we're really changing our approach to endometriosis as gynecologists. I don't always use surgery as a first option. I very rarely nowadays use surgery without involving physio, so I've got someone to help me through. The best way best way to prevent recurrence is probably to not have periods. So be on some sort of, usually hormonal therapy, to stop you from having periods. And that relates to one of the theories of how endometriosis starts, is that you get backflow through the uterus, through the fallopian tubes, you get backflow of blood and lining when you have a period, and one of the theories is that it can then implant. So by stopping you having periods, that reduces the chances of that happening. It will also hormonally suppress endometriosis. So if you've got little islands of endometriosis, and the problem with endometriosis is when it starts, it's invisible. It's visible to the naked eye. So there's a lot of endo that might be present that I can't see as a surgeon, and it's not till it's a bit more advanced that you can actually see it and therefore take it out. So usually following up with some sort of hormonal treatment is useful. That's difficult if you're planning a pregnancy, because most of the hormonal treatments we use, you won't be able to get pregnant because they also have a contraceptive effect as well.
And there was another one from the net, which possibly there's two together here. So if you've just arrived in the country and you've come with endo and you don't know what to do or where to go for treatment, where should you go? The second question was, why is it that some doctors and gynaes don't know a lot about endo? So those sort of go together.
From who do you go to? Look, finding a good GP I think is the key. There are a lot of GPs out there that have particular interests and experience in women's health. And it's, nowadays we've got the advantage of the internet of trying to find these people. But sometimes if you're not satisfied, then finding someone else who then can help you, educate you about the local facilities. Most cities in Australia will have big teaching hospitals that will have big gynecological services. So here we've got really the Women's, Monash and the Mercy. Each of those places have essentially dedicated endometriosis units. They all have different names, but at most public hospitals you will find that service. But it is hard to negotiate the system, and you are a little bit at the whim of who's helping you steer in that direction, and that just depends on people's experience really. As far as doctors and gynecologists not knowing about endometriosis, I'm really hopeful that the generation of doctors coming through now should know more about endometriosis. There's a lot to learn in medical school, that some things will fall to the wayside, and you tend to, ask me anything about orthopaedics, I don't have a clue, but, so you tend to remember things that you're interested in. But it's what I try to impress on the medical students I teach is that for most of you, half of your patients are going to be female, so it's really relevant for you to know how to ask a decent history about someone's periods, and to know, ask some basic questions. You can do it in 2 or 3 questions. When was your period? Are they regular or not? Are they painful or heavy? That's 3 really basic questions that any female patient, I think, should be asked. I still think medical schools have a lot of way to go as far as developing their curriculum around gynecology, which will then help develop interest. From a gynecologist point of view, so these are all specialists, as part of our training to learn about endometriosis, it's certainly something that's on our curriculum. It's something we should be knowing more about. But again, unless you're working in the field, you might not be getting the updates and so on. But in Victoria in particular, but in Australia, we do have a lot of people who are dedicated endometriosis specialists, pretty much, and that's forms the bulk of what we do. Unfortunately, there are a lot of people who aren't. We're not always good as doctors or as individuals to say, look, this isn't something I deal with. I would like someone else to deal with that, particularly with laparoscopic surgery. It's a fairly new type of surgery. It's really only become into, it's been around for years, but with advances in technology and digital cameras and lights, and we can see so much more than when the people that taught me when they started laparoscopy, they used to look down the eyepiece with their eye rather than having it on a camera. So that would really limit how much you could see. So I'm hoping in years to come, better technology, people knowing more about it. Certainly the group of trainees finishing sort of now compared with when I finished my training, which was over 10 years ago now, you know, their skill level with laparoscopic surgery in general is much higher than what mine was when I finished, because there's more people, you know, the skills are trickling down. There's more people who have a higher skill level who can then trickle, you know, and teach the people below them. So I'm really hoping that improves. But there are a lot of people out there. We need to find a better way of developing a register or something where we can express our interest. I mean, there are, the problem with the internet, you can say whatever you like, and that's with any profession. You know, that's it's basically an advertising tool, and it's hard to then go and, you know, get someone to qualify what their qualifications are, because they can say what they're good at, but you don't know that. It's just you know, it's like anything. There's, you know, how do you check out that there are certain clues that you might look for, such as if people have publications, if they've been involved in that, or if they're members of gynae endoscopy societies or members of endometriosis societies and pelvic pain societies, then you're going to find someone who has a bit more experience in the area. But it is really difficult. Really difficult.
Did you find that in your research, Beck, that when we found it hard to find people?
Yeah, particularly in the rural and remote areas, because I spoke to people all over Australia, and so a lot of the people in the rural and remote areas were actually travelling to major cities and interstate to get their surgeries and do their fertility treatments and things like that. I guess that's what we're kind of hoping for. If we can get funding with Endo Health to start training nurses in those regional areas, then at least someone there has some knowledge of endometriosis, and they can go to them, and then those nurses will have networks that they can refer to, so that you're getting some experience with endometriosis from that perspective.
And I think Liz's ideas of web treatment via Skyping and that sort of thing is fantastic. Do you have that kind of thing for dietetics? Could rural women do
Yes,
that with
absolutely.
you?
Yeah, there's so I also do Skype sessions, consults, and there are many other dietitians in private practice who do that. Yeah, absolutely.
Yeah. Have you done one yet, Liz?
Oh yes, I've been doing Skype for ages.
Okay, and that works well?
Works well, yeah.
Have you too, Chantelle?
Yeah, my whole team does Skype sessions.
Yeah. So it's brilliant.
Just like being there.
Yeah, actually, in some ways, I think for conditions like endometriosis, it's easier because you can also share your screen and run through the education with them, and so that it's kind of ingrained a little bit more than just a lot of talking, because we take away 10% of what gets talked about in the consultation. So you can send them homework, etc.
When we discussed some questions from the live feed, so someone has asked about a comment for magnesium for pain relief. Any comments about that?
Yes. So, absolutely, magnesium is known to help with pain relief, and so whether it is taking it as a supplement or making sure that it is in your diet, it's important and can help with pain.
And another question about someone said that they're worried that their two daughters will get endometriosis. Does anyone know the chance of passing on endometriosis to family members, daughters specifically?
Off the top of my head, I think it's 7 times as likely.
That's the number I use.
Okay, cool. So there is that. I guess we're still in the process of understanding how endometriosis forms, and we've got a lot of theories, but none of them have really been entirely proven. So in terms of the genetic link, it's increases your by 7 times more likely to get that. Not to say that if you have a daughter, but we'll definitely follow through, but that's what the research at the moment suggests.
And that does mean, like, for me, if I know someone's got a family history of endometriosis, then I may move towards laparoscopy a little bit sooner, or I may be a bit more assertive with treatment, with hormonal treatment, than otherwise, trying less invasive methods first. So sometimes just because you've had your experience with endometriosis doesn't always mean that your family members will have that same experience. It's not that definite a genetic link, but also new medications, new treatments, more awareness. We may be able to put other things in place to sort of stop that chronic pain cycle before it begins as well.
So I guess in addition to that, so now without the endometriosis awareness is raising, or more people are becoming aware of it. So if there's a parent that is worried that their daughter has endometriosis, so what's the treatment plan, or what's the path that we put them on now, so that they don't have to sit for 8 years and wait for a diagnosis? Does anyone have any suggestions on what do we do now? It's great that we know about it, but what's the first thing that we go, put them on the conveyor belt, go down this path?
I think starting with a really good GP is the place to start, and getting in a proper assessment as to what's going on, rather than just almost having a knee-jerk response and say, right, we'll put you on a pill. I think assessing someone and working out what's the best care plan for them, but making sure it's, and you're maintaining contact with that young person so that you're not just trying a one-off fix things and then off you go. It's about recognising that this could be a lifelong condition and listening to them. I mean, how many women have been told? I mean, even today I was seeing patients this morning who had been told, just ignore it. My mum didn't have any pelvic pain, is what a patient said today. She didn't have any pain with the period, so she didn't believe me. And this person's now in their 30s, and we're moving on to some management, but there's still that happens. So I'm hoping more awareness means at least people are listened to, and we can put in more things in place.
Any more from the net over there?
Someone just asked about a comment about sciatic endometriosis, and any tips on that, on care, self-care around sciatic endometriosis.
I'm not sure that I know much about sciatic endometriosis. Do they mean that there's actually endometriosis on their sciatic nerve?
I'm not sure.
I can't answer that.
I interpret that as being causing pain.
That's what I'm wondering if there's issues with a shooting. Yeah. So that absolutely would benefit from a physiotherapy assessment. Someone who's experienced in the world of endometriosis and has some good musculoskeletal assessment and treatment skills. There is no doubt a musculoskeletal component to that.
And of course we've also got pain specialists who can do assessments as well.
Yeah, we can look at medications and so on. I suppose I speak more generally because the word sciatic is used quite differently in the general population to how a physiotherapist might use that word. So yeah, maybe just shooting pains down the leg, which can be caused by many different things and may not need any sort of medication.
Here's another one on what's the best pain relief when you're breastfeeding. If you've got endo pain back after you've had a child.
Yeah, that's a really complicated question. I mean, there are a lot of things you can't take when you're breastfeeding, and you don't want anything that makes you too drowsy. Mixing that with a combination of having a little baby and breastfeeding. Look, I think that's something to discuss with your doctor or a pain specialist if it's getting beyond what your local GP can do. There's also a fantastic breastfeeding support or breast, I don't know what it's called, at Monash Hospital. The guy's name just completely escapes me. It's like a helpline, and you can ring and then ring him up and go.
Yes, because all the doctors call him.
Yeah, all the time, and he's the loveliest guy. Like I don't have no idea what he looks like.
Someone white.
Rodney White, that's who it is. So if you Google Rodney White Monash, you can ring him and his team with any questions.
Anyone in the public can call him.
He's amazing.
He's
he needs
happy to
medals.
answer questions.
He's lovely. It's always so delightful. And you never feel like an idiot when you're going, oh, what can this one? I think it's okay. And he just has it at the tip of his fingers and he looks it up, and he's always very reassuring and he's so knowledgeable. He definitely deserves an award of some sort. But that's a good place to start if you're unsure, particularly if you're breastfeeding, about whether it's safe.
Rodney White.
Someone else asked,
300
many doctors have told me having a child will cure my endometriosis. Is there any validity in this? Should I consider becoming a surrogate mother?
Yeah. The short answer is no, it won't cure your endometriosis. It will suppress it for a while. You will be distracted by having a small child for a while. But I would not recommend pregnancy as a way to manage your endometriosis. I wouldn't recommend surrogacy as a way to manage your endometriosis predominantly, because there are so many other things that being pregnant causes as well. That
like kids.
Yeah, like kids. Like, you know, we love them, but you know, and that's a lifelong commitment. You know, they're definitely not just for Christmas. So I think no, look, that has been an old doctor's tale. I'm going to call that, and I still see teenagers that get told, oh, you know, they either get told I'm not going to get pregnant, which is dangerous. I think I never tell anyone they're not going to get pregnant, unless they don't have a uterus. That's really the only person I would say you are not going to be able to get pregnant, because then you have a young person that goes, oh, I'm infertile. And that term also gets thrown around a bit. I'm infertile, and off they go and have sex, and then they get pregnant. But so they get told they're not going to get pregnant, or you need to have babies. You know, just go and get pregnant, and it will all get better after you have a baby, which isn't always the case.
Just a question. This is probably for you again. So, what are the best pain management tips you have for women with stage 4 endo and adeno? Would you recommend ketamine infusion treatment? That seems to be the hot word at the moment.
Yes. Look, that's a bit out of I tend to stick with what I know and know well. I leave specialty pain medications to pain specialists. But I would say, look, I wouldn't be concentrating just on pain relief medication. Physio and psychological support.
Hugely.
Without, I wouldn't say physio is the closest to magic that work for me.
That's very good. Thank you.
It is, no, like
there's
I've
a
had
lot you can do.
patients,
And patients are often really quite surprised by how much they can change. Not to say that we do everything and we are magical. It is very much a case of a combination of different therapies and practitioners. But if they're going down the line of a ketamine infusion, it'd be really interesting to know what has that person tried in the past, and have they had any physio input, and if they have, what did the physio do, what did they not do, and to maybe go back to some sort of physio input, maybe with a little bit of ketamine for the short term. Who knows?
I mean, you can't walk around with ketamine infusion.
You have to be in hospital.
Yeah.
Infusion.
So
you have
it's
to be
something
inpatient.
that's going to be a short-term fix.
Yeah.
It's not going to be something that you can live with day to day.
Yeah.
So that's where we need to look at all aspects of health we can have.
Yeah.
What about Botox?
The area of Botox in the pelvic floor is
Vaginismus, I imagine, for penetrative pain. And I would say that I don't often recommend vagina Botox because physios can help a huge amount.
So if you haven't been to pelvic floor physio and you're considering something like Botox, then it would be very, very beneficial to see a pelvic floor physio before you go and do Botox. There aren't many gynecologists in Melbourne that do it, but there are some, and they're all very familiar with pelvic floor physios too. So if you haven't seen a pelvic floor physio and you end up in a gynae's office who's offering Botox, they would likely send you to a pelvic floor physio for some what we call down training to help release and relax your pelvic floor. And for some people, it's absolutely the right thing to do. And again, it's often offered in combination with pelvic floor physio. So you might get Botox into your pelvic floor and come back and see us as well. It can provide a window of opportunity to do some really good work with your pelvic floor muscles.
So Kiera, someone's just asked how frequently do you visit the does someone come back to the pelvic physio?
So initially, we usually see, you'll have your first appointment, which is an hour long, and then I usually like to follow you up within 1 or 2 weeks, depending on the complexity, for want of a better term, of the person's presentation. I might see you every 2 weeks for 6 weeks to really get a really nice foundation of the education about pain, and make sure we've done an assessment to really understand the contributing factors, and then we base it on the person's scenario. How far away do they live financially? What can they afford? There's plenty that we can do. We could do Skype consultations, because there's heaps of education. I often spend a lot of time talking to people and it isn't all hands-on. And then we space it out according to the individual and depending on their goals, really, depending on how much feedback, validation, repetition of certain skills the person requires. Someone who's comes in and their particular concern is penetrative intercourse and they're having pain with that, whether they've got endo or not, generally that woman will be with us for 6 months at the minimum to 2 years.
Yeah.
And they wouldn't come every 2 weeks, it often gets quite spaced out, but your journey is generally that long.
What about, can bowel pain contribute to that as well? So the diet would be important in helping with those sort of pains?
Yes. So really looking at what the individual person's the symptoms are. They if they've got some gastrointestinal symptoms, then definitely have a look at those, and then working with that patient to address their specific symptoms.
Okay.
I have a question from, I think it's a really good one. It's so hard to keep positive when you have endometriosis. What are some strategies that we can use for the mind to help the body and to help us to cope? That's probably you.
Yeah. So I think that one of the important things is staying present, and because quite often we go ahead of ourselves. We think, is this how I'm always going to be? Then we get depressed. I think that my experience of the mind is that it really is never a positive place. Even if you're having a pretty good day, it's like, I'm all right today, but what's going to be tomorrow, whatever. And so I think the mind is generally a kind of an issue for us to learn to handle. Then when we have endo, it becomes more of an issue. So I think it's around focusing on what you can do. I think it's around looking at yourself in terms of what is my current capacity, and so what can I do today that would give me pleasure. I think that one of the really important things with endo is self-empowerment and feeling that you're in charge of your life, in charge of your body. And so I think we've all said this in different ways. I think your research was around people being self-empowered with self-care. So I think that one of the important things with endo is that you have your team, and that you have your team of people who you work with really well. And so, like Melissa was saying, she's like a conduit for referring to different modalities. I think that the dietitian and your food is really important. I think your mindset is important. I think your physical health is important. Your physio. There are a lot of other modalities. Acupuncture is really good for pain. Some people like Chinese medicine because it's a holistic view. So again, depending on what your philosophy is and how you look at life, if you're like a holistic person, then you might, having your Chinese medicine person might be someone who you go to, and all these things where you feel that you're in charge help your mindset terrifically, because you think, when things are going wrong, I've got my team. I think it's really hard to try and deal with it on your own, and I think then your mind can really play havoc with your emotions. So we think, right, I've got this pain, or I shouldn't have had the cheese last night, or I'm going to have the chocolate anyway. But I'm having a rebellious moment, and I know I'm going to suffer tomorrow. At least I have empowered myself to make that choice, and I know that's the consequences. But I think that dealing with endo is quite a big thing. And so I think that if you're going to deal with different aspects of your life, what I recommend is that you don't try and do it all at once. So you don't go to the physio, the dietitian, Dr. Chantelle. We have some research.
All appointments a week.
Yeah, because you'll kind of get appointment fatigue. And each area, I think you're wanting to find out and deal with it on its own rights, and so that you kind of have done the diet bits, so you know, right, these are the foods that trigger my endo, this is what I can do, this is what I can't do. Dealing with the emotional stresses and strains you have in your life, and how you're going to navigate your way through, setting your priorities, working with your energy, doing the things that are replenishing, that feed your spirit, if you like. These are that's another area. You know, if you're having the psychosexual, that's another area that really, because you don't have a lot of energy, you don't have a lot of energy to spread. And so I think it's really good to focus it on one area that you know, right, I got that nailed down. Now I know that one. And then you might look at your exercise and think, well, I can handle yoga, or I can handle a bit of Pilates, or I can handle gentle walks that keep me moving. And also being out in fresh air is a wonderful tonic on so many levels for your mind and your body and your spirit, because the fresh air kind of lifts your spirits, and the fresh air is really good for releasing stress and getting yourself back into balance. Doesn't cost you anything. And so if you're having a really bad day, to sit out on your back veranda with your heat pack and your cup of tea and just kind of connect to your natural environment takes your mind off yourself. And I'm not meaning that in a negative way, but just this is kind of lifts you. And so that's another thing that you can do. If your mind is in a bad space, one of the best things you can do is get that fresh air. That will lift you. Okay, I think that's
One of the best things I did, and sorry to barge in, is I actually joined the Epworth Freemasons Women's Endometriosis Support Group. So having a group of women that I can go to with endometriosis and actually who understand, and just have someone I can talk to and bounce ideas around. So for me, that was one of the best things I did.
And that breaks the isolation, because so often, like with endo, women who don't have endo and people who do have endo, they feel, what's with me, like as your sisters, if you like, think, well, I have a period and I'm okay, and you're kind of under the desk, you know, and so a lot of self-judgment comes into endo, because you're not like everyone else, because you actually have a real disease. It's not in your head. You know, you're not a wuss. You don't have a low. Often women with endo have a really high pain threshold and do it, cope with amazing things, considering what they're dealing with. And they need to be recognizing themselves for how well they're doing, not putting themselves down.
I guess another question that has come out after that is, how do we help to educate our co-workers that it's not just a little period? So anyone have any tips for?
You hear it all the time.
Yeah.
But, you know, it's such a joy when someone has a boss or in a work situation where they can appreciate it and they get told, no, you just go and look after yourself and do what you need to do. I don't have a lot of advice as to how to make it a better situation.
That's all right, as your wife has endo.
Well, I mean, I do write letters I see a lot of school children, so adolescents go through school, so I often, and I'm proactive in saying, do you want me to write a letter to your school and tell them what's going on? Not necessarily do I have to say the nitty-gritty of periods, because mostly adolescents don't want everyone to know about what's going on, but at least to try and educate the teachers that are looking after them, that there is something going on here. It's not in their head. It isn't just a little period. So I think I know that's what I can do with school. I haven't tried it with workplaces, but yeah.
You know, often you'll get a sympathetic boss if his wife is endo, anything else. But if someone who has had no contact with anything like that, then they can be a bit, cold and unkind.
We need more politicians with endo.
That's true. That's got a level of truth in that.
I know that with the implementation of the National Endometriosis Action Plan, they are looking at working with one of the employment groups to develop an employment pack, so that there will be like a workplace education thing happening to sort of raise that level. I know some of the advocacy organisations have actually done talks in workplaces to sort of promote awareness of that.
And just a question about, do you need a referral for a dietitian, a visit to the dietitian?
Yes, you don't need a
Yes, you
referral.
don't?
No. Sorry. Yes, acknowledging the question. No, you don't need a referral.
Okay,
Yeah.
thank you.
What about to psychology? Do you need referrals?
Psychology.
Yeah.
So you need a referral if you want to have a mental health plan, because then you get a rebate. But otherwise, no.
What about tuition?
Yeah, so sorry, with a dietitian to get a care plan as well, you do need to see a doctor first.
Yeah. Melissa, I think this is for you. Is PCOS more common with women who have endometriosis?
No, not necessarily. No, they're quite separate disorders. So no, is the short answer. Essentially.
Thank you. Any more from the audience? Yeah. There was a couple of people asking about nausea and fatigue. Why do they go hand in hand with endo? Are they symptoms of endo or are they symptoms of pain?
Look, it can certainly be, it could be pain, it can be endo affecting your gut and how your gut's feeling. It's a big inflammatory process. And we think there's some sort of immune function, immune function is somehow integral to the development of endo. And I see a lot of patients, I sort of have a triad of chronic fatigue syndrome, endometriosis and POTS, which is an orthostatic hypertension. I do see that triad quite a lot. So I wonder, if you've got a big inflammatory process going on, that exhausts you. You're in pain, it exhausts you. You're not sleeping well because you're in pain, so you're trying to work or go to school with all of these other things going on. There's lots of reasons why you can feel exhausted by endo.
And what's a novishore ablation?
So a novishore is ablation, and ablation or an endometrial ablation is burning the lining of the uterus. There are various devices to do that. The novishore is one of those devices. That's predominantly a treatment for heavy bleeding rather than painful bleeding. It wouldn't be appropriate in someone who wanted to have a child, wanted to have a pregnancy, because it would make the uterus unsuitable for a pregnancy, and if you get pregnant after an ablation, it can be a very complicated pregnancy. I always use it with caution, particularly in women who have adenomyosis, because it can make the pain from adenomyosis worse than what it was pre-op. But if, for someone with heavy bleeding who's tried other methods, it's not a hormonal method. It's usually done as a day procedure, similar to a hysteroscopy where we look inside the uterus. That's part of it. So it's a quick procedure. It takes, sort of set up time. The actual procedure usually takes a couple of minutes. Some places do offer it as an outpatient, so you're awake or under just very mild sedation. Not many places in Victoria offer that. People tend to be admitted to hospital for the day. But compared to, say, a hysterectomy, it's a quicker procedure, less risky procedure, quicker recovery, but not that guarantee of no bleeding. But predominantly a treatment for bleeding rather than pain. So.
Sorry, just with endo affecting egg quality, is there anything that you can do or any feedback in relation to that?
It's really tricky with endo and egg quality because age also has a big impact on egg quality. So as women, our fertility and egg quality starts to decline from our early 30s, from about the age of 32, and it makes a steeper decline by the time we get to 35, 36. And endometriosis, again being a really inflammatory condition, probably hastens that as well, that decline. Often you see women with endo having lower number of eggs and responding with less eggs in an IVF cycle. Some of that can be because of the endo, some of it can be because of the treatment, so the surgery. If you have endometriosis cysts, those cysts on the ovaries or in the ovaries, then inevitably when you have your ovary treated, that can damage the ovary, cause further damage, so you've got this double whammy. So there's not a lot you can do apart from trying to prevent the endo from its earliest as possible. Or halt or slow down the progression of endo.
Okay, so any more questions from the men?
Is excision a better option to ablation surgery?
I think so. Sorry, that's my question. Sorry, I just jumped in there, sorry. Yes, look, I think so. Endometriosis is often, and this is often where the experience of the operator comes into be. It's technically often a bit easier just to burn something, so you just touch it with something hot and burn it, as opposed to excise it. Endometriosis is often like an iceberg, so you can see a little bit on the top, but then if you actually feel the tissues underneath, you can feel the thickening and the scarring of the tissues underneath. So burning the top, you're really just melting the top of the iceberg really. You're not always going to deal with what's underneath the endo. It's a very different skill set to be able to excise endometriosis than it is just to burn it, which nowadays people being trained in obstetrics and gynae and receiving training in laparoscopy would, in my experience, most of the time be taught excisional treatment as opposed to ablation. If you've got very mild endometriosis, so a little patch here or there, then ablation, there's probably not a lot of difference between ablation and excision. But certainly nodular endometriosis, where it's a bit more advanced, just ablating it isn't really going to get to most of the problem. But also won't deal with the scarring, and it's the sort of disease that really kind of drags the tissues in, and you feel tissues that have endometriosis and they're tight and they don't move very well. So just burning it isn't going to change that. So you really need to excise the disease plus the scarring around it as well to get then that will hopefully be replaced by healthy tissue.
Thank you. There aren't any more questions, but there is deep appreciation from the online audience to say thank you all for your time and your expertise tonight, and everyone appreciates being heard. Thank you to Epworth as well.
And on that note, we've just hit 7:30, so probably have to wind up. So maybe we could just go on the panel again and just one gem from each person. Something, that's, that your one piece of advice you'd give somebody.
Which I've already said,
Yes.
but really just that a musculoskeletal input, pelvic floor input, education about pain and persistent pain can change your experience of pain quite a lot. So it's worth actually going through that journey if you haven't yet done it.
Liz?
I think if you start to feel how much energy have I got in my system, and this is what I want to achieve, and do I actually have the energy to do it, and make decisions based on your energetic capacity versus what your mind is telling you, then you will make better choices. Because if you don't have the energy today, maybe you'll have it tomorrow. And it's not like never, it's just that, okay, if I don't have the energy today, what could I do to be replenishing myself so that I can do it tomorrow? Rather than getting yourself on that hamster wheel of pushing yourself past your point.
I think definitely if you're experiencing a lot of pain, speak up about it and make sure that you're getting the help that you need for the symptoms that you're experiencing. If you are having those pains, then seeing a dietitian and really making sure that you find a dietitian that you can work well with to really get on top of those symptoms. I think it's really important.
I'm going to piggyback off you because I like the way that you said that. If endometriosis or if you have health conditions that are affecting your relationship, your own sexuality, again, speak up about it because you have such an amazing team that can work with you to focus on relationship satisfaction and sexual satisfaction. So the journey, not so much the destination of penetration orgasm, for example.
I think if you're someone with endometriosis, trust yourself. You know what's happening inside of your body. You know what your symptoms are and what you're feeling. And finding that team of professionals. I don't think it's a one thing is going to fix everything. There's no magic cure. So I think having a team of professionals that you can go to that can support you with each of your symptoms is probably the way to go.
I was saying what she was saying. And I think most places in Australia will have experienced, dedicated people who can help you, that don't be afraid to change. People change doctors all the time. There are a lot of people that will change. Don't be afraid. Your doctor might take a bit of an ego hit, but will survive. So it's okay. And people change. And it's about finding the person and the team that's right for you as well, because different people need different style of doctors. If you're talking about doctor point of view, but accessing all these other fantastic people that we've got, if you've got someone who's just trying to be just single-minded doctory about it, then you've got that education now that you know there are other things that you can do to try and help. Because really, as doctors, we're very, like as gynaecologists, this is my area. Above the below the belly button, above the knees. That's about it. Apart from that, we're not well trained on a more holistic level. I mean, I can appreciate it, but I just don't have the knowledge to give you as much practical advice as all these guys can.
So probably to follow on from that, people have just asked about contacting, how do we go about contacting people on the panel after tonight?
Well, how about, can we get the camera on? This is our support group. Don't know if you can, but if you just go to the Epworth website, there's a link to our endometriosis support group. You can email me and I can just email
How often does
details.
that support group meet, Wendy?
Well, once every 2 months, but we seem to have moved to once a month due to popular demand. And I'd just like to thank all the panel as well. I've just been fantastic and they're always supporting us. It's been really good, the experts that we've had and all the girls in the group as well. Women, sorry.
And the boys.
And partners are extraordinary. And Louisa for helping with, or doing all the media here. And also just wanted to say hello to everybody around Australia because I know and New Zealand. Yes. And they're all, there's some fantastic support groups out there that are spreading the word all over the place. So that's fantastic. And also obviously thanks to Epworth for supporting this group since probably 2012, I think.